So today what I'm looking at is guidelines and medical treatments for female androgenetic alopecia. And we know that in females, the presentation is much different, where men tend to sort of have a certain pattern that is quite recognizable. In women, you get a general thinning of the hair throughout the whole crown. And you have to be careful whether this is telogen effluvium, whether it's diffuse thinning secondary to some nutrient, or whether it's actually female pattern baldness. It's characterized by non-scarring progressive miniaturization of the follicle, and as I said, it occurs in a specific pattern. Its etiology is multifactorial and polygenetic, whereas we know in men it's directly related to dihydroxyandrosterone, which is a precursor of testosterone. In women, it's not. And this is the type of pattern that we tend to get. Diffuse thinning of the centroparietal region, also with, you preserve obviously the sort of the frontal hairline. And if women present to you with thinning or the hair missing on the frontal area, you have to consider FFA, which of course is probably a variant of flaccid plainness. FFA, everybody thinks you lose your eyebrows with it. Many of the patients you don't tend to, and it'll be picked up on biopsy. So female androgenetic alopecia is present in all ethnicities. It increases like male pattern baldness with age. It's a higher prevalence among Caucasian population, and at 70 years, over 40% of patients in the Western world suffer from the condition. As I say, we don't really know what causes the condition per se. Androgen dependence is uncertain, and there's a subset that certainly tend to be suffering from some hormone dysregulation. Usually it's diagnosed by examination of the hair in the scalp. You may have to do the sort of pull test. Usually if you get a dermoscope as well, and you look, you will see the sort of pattern of hair thinning in the central parietal area. What I've decided to do is just look across all the literature for Cochrane studies at level 0, 1, and 2 to see what evidences are out there for what works. So we analysed 77 different papers at different levels, and level 1 is obviously the best, where you have random controlled trials. Level 2 is trials done without randomization. Level 3 is just cohort controls. And all the way to level 4, which if a respected doctor said that this works in his experience, but he hasn't done any clinical trials, it's acceptable as some level of scientific study. So the first one, I suppose, that we looked at per se to break down was the use of minoxidil, then the 5-alpha reductase inhibitors, then hormones, then things like low-level light therapy, and then products. And I suppose I'm a bit hard on things like PRP, because when I originally started giving this lecture, the evidence for PRP was less than it is now per se. Minoxidil, as you know, came from a drug that was originally used to treat blood pressure, and like a lot of our advances in medicine, it was because of a reason that it was used for something else. All our psychiatry medicines for depression, as you know, came from blood pressure tablets originally. Rauwolfa in the late 50s causing depression. And it was pretty much the same thing for Lonitin when it came out. It reduced blood pressure, but it also caused hair to grow, particularly in females. The jury's out, I suppose, on the 5% per se. We tend to sort of certainly use the 2%, but there's some FDA trials going through now to show that the 5% maybe worked as well. Minoxidil works by transforming itself into an active metabolite, minoxidil sulfate, and that opens up ATP-sensitive potassium channels, and you get a vasodilatory effect. So of all the studies, the conclusion came that the 1% solution applied twice daily did increase hair count to an extent that 2% showed almost the best, and that there wasn't an awful lot of difference between the 2% and the 5%. Now, Neil Sadek was chatting to me a few months ago regarding this, and he's putting through some trials regarding the 5%. In terms of finasteride, We know there are 2 different types, and the 1% is widely used, I suppose, among males. In terms of the therapeutic recommendation in females, it's not suggested that postmenopausal women should use it at all, though it does say high-quality clinical trials at different dosages should probably be tried. In all the studies, the postmenopausal female, the 1 gram failed to show any efficacy at level 2. In terms of Dianet, the role of androgens regarding androgenetic alopecia, I suppose, has led to some hormonal drugs for this treatment. In terms of therapeutic recommendations, Dianet can only be considered to be used in patients with biochemical evidence of hyperandrogenism, and in terms of the ordinary use of it among female androgenetic alopecia, there isn't enough evidence to support its use. In terms of hormones, I suppose all our companies tend to make products that are out there, and we sell them as well in our clinic, but there isn't, I suppose, a lot of evidence to support the topical use of some of them. Alpha-estradiol, for instance, didn't show or prevent progression, and there isn't a great lot of evidence also to support the use of topical estrogen or progesterones, even though we use them and the patients tend to like them. Most of the products will work by 1 of 5 methods: either promotion of hair growth by activation of the dermal papilla, that they'll have some vasodilatory effect similar to minoxidil by promoting hair regrowth that way, an anti-inflammatory action, improvement of hair follicle function, or inhibition of dihydroxyandrosterone. And there's lots of products, as you know: aloe vera, caffeine, melatonin, the retinoids, iron supplements, amino acids. And obviously, if you have other reasons for losing your hair, including diffuse hair loss, and you know the difference because you lose it at the sides, you lose it at the back, whereas with FFA, you'll only lose it in the central parietal area. Some of these products are going to have an effect for some of the other methods. But most women, when they come in, they'll have to be worked up for iron loss, vitamin B12, hyperthyroidism. You know yourself, the basic dermatological workup. Some of the products are shown to have some effect, and particularly low-level laser. I mean, there's a whole market out there. We know now that probably it's not just working through the use of cyclic AMT, but also it can affect the genome that causes shedding. So not only do you improve hair growth directly through its own vasodilatory effect, but you also improve the fact that less hair is shed. In terms of hair products, it is a little more difficult, but there is some evidence, particularly for patients that are on amino acid with cysteine and with zinc, and patients particularly that have zinc or copper deficiencies, that subset showed a benefit. There is also evidence that biotin and niacin have hair-promoting properties, and Drelius et al. Took 60 patients, and after 6 months, 69 were rated as improved by photographic assessment. A lot of other products as well that are sort of on the borderline showed some effect. Caffeine, for instance, was claimed to be effective, and topical use of melatonin, even though in a lot of papers, a bit like PPP, that shows some evidence. If you put it to strict, I suppose, guidelines, scientific guidelines to fit the Cochrane level, because they're not blind, they're not randomized trials, they didn't fit the inclusion criteria of this. In terms of mesotherapy, and there wasn't great evidence to support efficacy. PRP, the jury's out a little bit. I know in some places like Dubai, they still don't welcome it because the scientific evidence isn't strong enough. And I suppose that's our fault, really, because I've sat and watched many doctors talk about PRP, but they're not doing split head studies, they're not doing randomized studies, they're not doing double-blind studies. So if you're just doing PRP and saying, look at hair grows, that's not enough within the scientific community to have an adequate level 1 study. Low-level light therapy, as you know, it certainly is, has a market. Excuse me. Its downside is obviously it needs maybe about 20 treatments, but what we do in our clinic is we often do PPP, which is protein poor platelets, put it within the, I suppose, bowls for the follicle solution. Instead of sort of doing PRP and injecting in, have the stem cells on the bottom of the follicle put in at the same time, and then put the patient in and have red light on the same day. And that works within us. Sorry, I have to run to another lecture now at 9 o'clock. Thank you.